corridor and get sick. But again, that same thing as Ebola. If you look to the symptoms there at the beginning, they're very non-specific. This is another febrile flu-like illness when it's in its early phases. So really it does rely on, again, an understanding of your travel. So we're not at zero risk that someone else will return to the United States in the future, having been to Argentina and having picked up, or Bolivia or Chile, and having picked up hantavirus. So again, that first question of like, have you traveled outside the United States in the last few weeks actually becomes really crucial, because you won't be able to differentiate it based on symptoms alone. I'll pause and catch my breath before talking about other explosions. I'm not sure if anyone had specific questions about those two things so far.
There's a question in the chat, Dr. Wolf, and it says, in regard to effect in regions affected by ongoing conflict or with lack of resources, how can they build resilient local health systems that handle these outbreaks without relying heavily and solely on international aid?
Yeah, boy, there's a PhD in a question, isn't there? I think the question could be both based around Eastern Congo or frankly, some of the poorer areas of South America. Congo's a tricky one. Congo's a tricky one because the country as a whole struggles on a finance point of view. So their ability to invest in health resources in the same way that we may do here or in Europe or Australia is limited. Similarly, there has been in the past, both through war and government inefficiencies and other reasons, a lot of skepticism about healthcare interventions. And so I think that what was ultimately successful, if I could parallel back to what happened 12 years ago, is that there were very large efforts to try and put in educational programs within those countries to at least say, here are correct ways of looking after burials in an outbreak. Here are correct things to think about in terms of symptom identification. Here are the forward deployment of vaccines that we know to be effective. Unfortunately, in this instance, there was actually Ebola vaccines deployed in East Africa, in Eastern Congo. It just so happened that this was a totally different strain. But at least having some community awareness that this is going to be an ongoing issue for parts of the Congo. Hantavirus in Argentina and Chile and Peru is also a condition of poverty to some extent. It is spread by and transmitted by rodents, and people living in areas where they may be exposed to those more frequently are going to be at greater risk. And so, again, I think there's an education of clinicians in those settings to recognize symptoms. There is a need for public awareness of the transmissibility of that. And again, sort of visibility that if you're sick for more than a few days, then you've got to turn up. All of that requires an investment in terms of education and time. And I don't know that we should reasonably expect local governments to be able to do all that education by themselves without some of our support to kickstart it going. Again, we could do a PhD on that question alone. It's a tricky one, and clearly, whatever we've done in the past is not perfect because we still have these outbreaks ongoing. So, rethinking it is important.
This is Dr. Kaplan. I can ask maybe a question without going through the chat. So, when it comes to Ebola, is so much of this is through butchering, preparing bat meat, consuming meat, bat meat. Is that driven by poverty, or is that a social norm in those cultures?
Yeah, good question. It's probably a bit of both, in actual fact. Definitely some of it is poverty related. So we do know there's lots of traditional hunting of bushmeat in those areas, both by community members, but also by militia, who then travel back and forth and don't sort of have the same community or healthcare connectivity as the local population would have. Some of that can be behavioral, teachably modifiable behavior. I do think folks in West Africa have become much more cautious about their interaction with bushmeat and bats in particular in the aftermath of the epidemic. So in answer to your question, a little bit of both.
Thank you.
Also, has the hantavirus been found in the mid-Atlantic states or totally in the Southwest?
Yeah, so if I go back to the slide of where it is, these are recent cases. I think this is the last, this might have been the last 10 years worth of cases. You can see that there's cases that exist in the light yellow. Many of those were probably locally acquired in the west of the country, though. Like the one case that exists, for example, in North Carolina is geolocated to downtown Charlotte, which I just have to presume is a traveler, because I think you would see more outbreaks if it was more co-located here. And I think it makes sense as a sort of dusty environment, inhalational transmitted illness, that it would be less common in the sort of Far East and Northeast. So I think I would put this on the same as some of our fungal conditions, for example, that are epidemiologically linked to the Southwest, like coccidioides, would look exactly the same as this heat map. So predominantly a Southwest illness. Not to say we don't all travel across the country routinely. Like, how many people here go to Arizona each year? It's probably quite a few. So I'll move on to Cyclospora, because this is certainly the hot topic, at least it is for us in North Carolina, and unfortunately also it probably should be for you guys in Virginia. So Cyclospora is not new. It is a parasite that causes a significant diarrhea, as we'll describe, but we would typically get summer clustering outbreaks of Cyclospora in the US most years in many states. But I want to emphasize the fact that this is grossly larger than what we would typically see. The standard sort of summer months, in fact, are when we see the uptick of cases across the year. We can go into why that's the case. But I want to start by saying this is markedly higher than what we would typically see, and that's assuming that we're counting the cases correctly, which I'm not sure we are. So a little bit of background micro. Cyclospora is a parasite, so it does tend to be both more challenging to diagnose, slower to cause its problems, and harder to eradicate. So it is a hand-to-mouth parasite. It's a GI tract parasite. It's not one that invades into the rest of our tissues, but it is really felt to be a human-only pathogen. So we don't know of any local, like rodents for hantavirus. We don't know of any vectors that naturally transmit this. We think this is ultimately person-to-person ongoing circulation in the community. Even though if I'm sick with Cyclospora diarrhea, I cannot infect another person. So, unlike norovirus, for example, where we know we get big clusters of outbreaks, this really does not transmit in that way. So it actually needs humans to replicate. We continue to be part of its sexual reproduction cycle. So we eat a sporulated oocyte or an egg. It goes to our small intestine. We know that it has a sexual reproduction cycle within our intestines, and then we shed it out in our stool. And presumably, all of our transmissions at some point are related to ineffective human management of our own waste and recontamination of food cycles, and the cycle continues. It's slow compared to most other food poisonings because it's a parasite. It needs to divide, it needs to grow, it does that slower. So, I tend to think of toxin-mediated diarrhea as being one where the preformed toxin, the toxin's going to work immediately. If you have a bad chicken or rice and it's got a preformed staph toxin or Bacillus cereus, you're going to get sick within a matter of hours. Bacterial food poisoning does require some bacterial growth, but that's quicker. And so those individuals, your raw eggs or raw chicken, will get sick within 12 to 24, 36 hours. This is slow. The average is at least a week. So again, thinking about how to pin down where an outbreak is coming from, it's really hard to know what I ate yesterday, let alone what I ate a week ago. And so for people to sort of track back actually takes a lot of human manpower from an epidemiologic point of view to figure out what might have been on someone's individual menu. It presents somewhat nondescript. It's a watery diarrhea, tends not to be bloody, but people will talk about anorexia, cramping, bloating. And then the real challenge is that not only is it slow to begin, it's slow to go away. So lots of people will talk about ongoing or even relapsing and remitting symptoms that can sometimes last a couple of weeks. So I think they're the differentiating factors to me, is that it's a slow onset. You won't get explosive clusters of, sort of 20 people at the barbecue, but they may not be able to remember the source of the barbecue a week later as individual people get sick. And then it lasts for quite a while. It's something that's going to be missed on our routine stool tests. So the old days of the lab, sort of looking down the O&P slide, probably gone for most of our labs, because most of our automation has eliminated the person in the lab looking down the stool who might have been able to astutely pick this up. It's not found on a standard stool culture. And so actually really our diagnostics these days are either reliant on you having a high enough suspicion to tell your lab team, I want an acid fast stain. And so to go back to the original picture, the cyst on the left is acidically stained. It coats the capsule of the parasite. That's labor intensive. So most labs won't do that these days and will preferentially go to either a monoplex PCR or a multiplex. For us, it's a biofire PCR, which will actually give you a 20 pathogen readout of different things that cause diarrhea. Ultimately, the management is also a little bit tricky. Most people probably will clear this by themselves. In fact, there's a very strong sense that there's a large number of people who are probably asymptomatic shedders, and enabling this to continue to perpetuate. However, the people who I feel like I'm the most concerned by is elderly or those with real difficulty controlling fluid balance. So if you've got heart failure, if you've got end-stage renal failure, your challenge with facing an unrelenting diarrhea is going to be higher. And folks who are immunocompromised at the end of the day can't control this as efficiently as the rest of us. And so they will end up with more severe and more persistent disease. So because most people will clear it, actually, most people don't need treatment. That said, by the time we're finding out that they've got cyclospora, that means that they're probably already sick for a bunch of days, if not weeks. They may have already gone through simple at-home management, not got any better, or they may be high risk and feeling unwell. And so actually Bactrim has proven to be really effective for this. So 7 days of standard double dose twice a day Bactrim is usually sufficient. If you've got someone who is sulfur allergic, is struggling with hyperkalemia, which that sort of dosing of Bactrim would certainly run the risk of. Cipro is an alternative, although we think the efficacy is probably a little bit less. Where I think it's important is trying to track this down. So like I said, we do get summer outbreaks from time to time. In fact, most years across the country, there's some little clusters. But usually we've been able to pin down where it's coming from, and people would see like certain items are removed from the food shelf because we know that there was contamination. We do not have the public health bandwidth at the moment in our state, and certainly not in our county public health labs and epidemiology services to actually be going back through individual cases and really working through this. So as people would know, it's now been, this has been evolving for now a couple of months, and we still don't really have the answer. Similarly, our CDC collection has been difficult. Some states are now are electing that this is elective reporting. It's most commonly associated with fresh fruit and vegetables. Raspberries, cilantro, and some of our herbs are the most common. Michigan's health department, where there's been the most cases, think that they've linked an association with bagged lettuce, but that is not definitive. And I would say that now that we've got multiple thousands of cases, it's probably likely that we've got multiple point sources. So actually the prevention message is really easy. You can't see it. You can't look at your food and assume that because you can't see any dirt or grit on it, that therefore it's not contaminated. So we actually go back to basics and we just tell people, you got to wash your fruit and vegetables, period. Like that should have been not rocket science for us in terms of public health messaging for the last 20 years. And yet here we are with a multi-thousand person outbreak. You can cook your way out of a parasite. So high intensity cooking will certainly clean this, but it's not you can't just wash your vegetables in hot water and assume that that'll be gone. It actually needs to be a bit of a thorough clean. But this is certainly preventable, I think, is the take home. I'm going to go to measles. I wish we didn't have to, but I think it's sort of off the front page of the news, but it is not off the agenda and worth us thinking about. So a look to the table on the left. We've already had now more cases, because this data is, I think, a month old, more cases in the first 6 months of this year than we've had 7 months than we had all of last year. So this is not under control nationally for us, and is likely, as we'll get into, to represent now ongoing endemic transmission within the United States. It still mainly affects kids. It's been overwhelming with the number of people who presented. And we're probably actually sitting a bit less in terms of hospitalization than what we thought about. Traditional teaching would say 20% of people need hospitalization. It looks like it's probably more like around 10% these days. And there were some fatalities. But the key to the bottom left here is for me, the overwhelming majority of our individuals who've got sick are unvaccinated. There are some, and I think it's important to say, who either had insufficient vaccines or, as we know, it's not a 100% effective vaccine. There are some immunocompromised individuals or people who just don't seem to mount a response to MMR. They make up a minority of the cases, despite some anti-vaccine themes wanting to latch onto those patients as a reason to sort of be nihilistic about vaccination. Here's our week-by-week caseload. So that first peak that you see in sort of spring of 2025 was the big West Texas outbreak in and around Lubbock. And then the giant outbreak that you see in sort of December, January, February was really centered around Spartanburg in South Carolina. I think the message here to me is look at those intervening weeks. You see prior to 2024 that we would get 1 or 2 cases a week in the US, and they were almost always flown in. But now we have a baseline level of ongoing transmission, even when we're not in a sort of clustered outbreak setting like what occurred in South Carolina. And I think that's the issue here, is we've seeded so many little measles spot fires across the country that it is not burning itself out. It's particularly not burning ourselves out in the mid-Atlantic, which is a big issue for us. And Virginia's had its share, unfortunately, closer up towards Charlottesville, with some communities that are really significantly under-vaccinated. And that was the case in South Carolina too. Most of the North Carolina cases, unfortunately, have been bleed-overs from south of our border. But this has been an ongoing issue, and it really does center around communities that have, for different reasons, chosen to aggressively not vaccinate individuals. It is the single most contagious thing that we know. So for every one person who's infected and infectious, they'll on average affect up to 18 at-risk people around them. So if you're in a school where your vaccination rate is low, you should expect a rolling outbreak. The idea is that if we get above a calculated rate of 95% of our community being vaccinated, even if you're the one person who brings in measles into that community, there's no unprotected people who you can come in contact with, and it will burn itself out. Unfortunately, we have most states in the US now are beneath the threshold where spontaneous disease burnout occurs. So we are seeing these rolling events. It's also tricky. So when we look at the sort of evolution of measles within humans, there's again a 10 to 14 day incubation period. So you can travel a bloody long way in 2 weeks and forget who you might have run into who had that weird rash 2 weeks ago. It's hard to track down cases. In fact, as you start to get sick with a flu-like illness, you are contagious before the rash appears. The rash is usually that one thing that when you start seeing it, makes the penny drop for most clinicians, myself included. But unfortunately, that person's already probably had flu-like symptoms, trying to manage themselves at home for a few days, and they've been highly contagious during that period of time. Cough, conjunctivitis, coryzal symptoms, the 3 Cs being the main thing that we're worried about. You can, for folks who really want to do it, there was a beautiful review by some Australian colleagues last year that sort of went through in detail clinical management and signs to think about for measles. The rash is pretty nondescript. Like, it's not a slam dunk that someone would look at this and lots of people think, is it a drug allergy? Is it poison ivy? Is it any number of other viral illnesses? It is harder in dark skin to identify it. We don't think of, like, all the pictures that we see in textbooks are painfully associated with white skin. This is just a condition of all skin. We have to realize that. And there is this classic sort of thing in the mouth called Koplik spots, but I think really if you're trying to use little hemorrhagic lesions in the mouth as your telltale sign of measles, you probably missed a few days of infectivity along the way. Like, teenagers and adults look exactly the same as young kids. It's a widespread rash, classically starting head, working its way down to the tail, to the feet. If it was just a rash, no one would, I think, particularly care. But the problem is it's dehydration, it's middle ear damage, it's viral pneumonia, it is encephalitis in a rare group of people, thankfully. And then we also deposit measles in our brain. And so there is this, frankly, horrific reality that there's this thing called sclerosing panencephalitis, that essentially measles will wake up and cause a rapid dementing process about 7 to 10 years later, which is untreatable and horrific to think that we've now seeded that potential for actually many thousands of people in our community. There's not a treatment. We talk a lot about vitamin A. Vitamin A was this interesting sort of misnomer. There is data to support grossly malnourished communities outside the United States do have less severe measles if they've had vitamin A supplementation. We typically do not see vitamin A deficient individuals in the United States, so this is not a panacea, unfortunately, although some people will still use it. And we talk about vitamins all the time. In fact, all the way up to the boss of our HHS talks about it. It's an easy appeal. It gives us a sense of control. It helps us sometimes bypass healthcare, but at the end of the day, it just doesn't work. There are antibody developments and some antivirals that are cooking. I would say these are up to phase 2 now, trials, but we're some years away from this becoming mainstream. Why it's important to identify it is you actually have a little bit of intervention time when you can make a difference. So there's really good outbreak data that says if you're unvaccinated and you've been exposed and you're now willing to receive a vaccine, it's very, very effective. So we have this short little 6-day window when if you have been exposed and I can get you a vaccine, it's in fact very successful. Or if need be, you can't take a vaccine, maybe you're pregnant, maybe you're immunosuppressed, we can give someone antibody infusion. So there is this desire to want to know about cases because we can prevent more. I'll skip through some vaccine hesitancy slides, but I'll come back to these if folks want. It is relevant. I promised Mike that I would talk a little bit about what's coming in terms of vaccines in other realms for the upcoming months. Unfortunately, there's not a lot of changes here, so this hopefully will be a reassuring discussion. Flu shots. Last year, we faced the reality of how slow our flu vaccine development process is. We have to say to manufacturers in sort of February and March, here are the ingredient strains, seed strains that we want you to grow in your eggs. Think of the number of chickens who support our vaccine industry in order for that vaccine to be available for our winter season. And so if a new strain appears, as it did last year, which was subclade K, we may have missed the opportunity to put that vaccine strain into the jab. Reassuringly, actually, now we may have our first mRNA flu shot, and so I'm hopeful that the technology will, in fact, bend in the direction of being able to have more rapid updates about strain variation. We've updated the strains this year in the flu shot. The recommendations are still the same. Everyone is recommended to have a shot. I would say the emphasis is on healthcare workers. We do not want to be the vector about making our patients sick. We often have young kids at home. I've got a 10-year-old here who can't control his own snot. So we are the vectors in many people. Certainly those over 65, there's now data to support the higher dose vaccine strategies or recombinant strategies being better. If you're 65, 70, 75, you do not respond to the standard flu vaccine to the same degree. So we up the dose and it's very effective. COVID, actually not many changes. So the same 3 vaccines are still all that we have. And I think although the recommendations are sort of officially blurred a little bit in terms of who should receive one, people are worth knowing your risk of coming in to need to see a doctor, an emergency room, and urgent care, getting admitted, goes down by about half if you've had a vaccine. So to me, if you're the well 35-year-old who has no healthcare conditions, your risk of going to the hospital anyway is remarkably small. So I don't really care about vaccinating you at the moment. Priority again, young kids not previously vaccinated, older adults over 65, those with significant comorbidities, and clearly those who are pregnant. And that is a 1A recommendation still from our OB-GYN colleagues. RSV has been around now for a couple of years. So this is the sort of the triple vaccine threat as we come into every winter. Again, there's 3 options. We now actually have an mRNA RSV vaccine that was proven to be just as effective as the traditional 2, Pfizer and GSK. This equally does really well in the first year. So if you could say to patients, hey, dear person with some emphysema, you have a 75% reduction of likelihood of needing to come in to see a doctor by getting RSV from this vaccine, like that's very meaningful intervention. It drops away a bit in the second year, but still a meaningful intervention that we should be thinking about. It is targeted now at those over the age of 75. So our RSV risk really accelerates after 75 and into our 80s, or those who are pregnant. And the pregnancy one's a tricky one because we would like to vaccinate you in your 3rd trimester with enough time before your delivery in order to mount an antibody response. But there's no point in doing that if it's February and RSV is about to vanish. So the point is to get antibodies into the newborn such that when they're born in the middle of the winter, they've got some innate protection. At this stage, we don't think there's a need for a second dose, but it's actually too early for these to be on the market to really know. I think particularly our immunosuppressed people are going to need a second dose, and that'll be a likely recommendation within the next year or so. Final little piece of data. I still run into parents who, don't think that flu is an issue for their kid or don't think that the vaccine really works. And so actually this was a CDC paper published very recently that looked back at every single year, independent of how good we got the vaccine match. That's always a talking point each year. Unfortunately, while pediatric deaths due to flu are rare, there's always a couple of hundred each year. And every single year here, generally the cutoff is whichever way you cut this data, it's about a 70% reduction in pediatric flu deaths if that person's had a shot. So I try and preach the message, look, it's not going to be perfect. If you're sitting next to the person who's sneezing all over you, there's a fair chance that vaccine may not work, but it will absolutely help you in terms of avoiding a severe case. I'm going to pause with one final little troublesome thing to me. It's harder these days to find good data. It's harder to point patients in the direction of good data. And even my own colleagues and I struggle to go, do we look at the CDC anymore for sort of good information? It's behind, for example, on cyclospora updates. And I think while I have good faith in what the CDC is putting forward as being accurate, I don't know what they're not putting forward. And in fact, I do know that the cuts to their bank of public health staff means that they're literally not able to put forward as much as they may have already done. So here are just my examples of actually the 4 groups who I routinely go to. Immunize.org has a wonderful data set of really very patient-centric information about different vaccines, who they're used for and whose guidance recommends them. CIDRAP is an academic institution based out of the University of Minnesota, which has a beautiful day-by-day updated outbreak guidance. It has really good data. It's global in its focus, but US-centric. If you're after some updated information or concerns about outbreaks, it's I think one of the best data sets. And then if you're just purely after vaccine information and recommendations, the Academy of Peds, if you're looking after kids, or the American Association of Family Practitioners, I think do a really good job of saying, here is our recommendations. It's very similar to what they had in 2024. And so I take better confidence to say, no matter what sort of politicizing is occurring or may occur in the future, this is based on good data. So I'll pause there, and I'll actually stop sharing. And if people had questions, by all means, I've gone a little bit over time. I wanted to leave a little bit of extra time for questions, but equally, if folks want to have questions or email afterwards, you've got my details there.
Dr. Pradhan, you have a question?
Yes, sir. Can you hear me?
Yeah, I can. How are you?
Perfect. Dr. Wolf, thank you. Always. I know you've been coming a couple of years and enjoy your talk. Thank you very much for updating us. Quick question. I know viral infections always keeps on the toes. What is the update on COVID? Now, I know in 2026, new COVID vaccine has not come. Any update you can share with us? And what do you think about COVID augmenting other viral infection, i.e. RSV? And 3 years ago, RSV was, we had it, but we didn't pay attention to it. Now it's become very important. Thankfully, we have effective vaccine, which is being encouraged and people are taking it. So can you update on those two? Thank you.
Yeah, it's a good question. So you're right, there's not an official update to COVID vaccine guidance. I went hunting for it today thinking that it may have been. It's not there. I think it reflects a couple of things. I think it probably reflects a little bit of politics, truth be told. I think it also reflects the fact that we've not seen a substantively different strain or clade of COVID emerge in the last few months that has in any way affected clinical endpoints. So I think to me, what that leaves me sitting back on is the last 2 or 3 years, actually, the data has looked very similar that a COVID boost will reduce your chance of a medically attended visit by about 50%. So to me, if you're the 75-year-old, if you're my transplant recipient, if you've got lupus, if you've got heart failure, if I can reduce your risk of coming into the hospital with a viral illness by 50%, I should do it. I do that with flu, so why shouldn't I do it with COVID? We toyed a lot with combination drugs, combination vaccines, of having flu and COVID in the same jab, and I think the somewhat anti-mRNA sentiment has probably killed that off, sadly. It does not seem to be appearing on the horizon. Your question about RSV is an interesting one. There was a lot of work done early on in the pandemic to say, could COVID be amplifying other viruses? And I do think there was something that ultimately was shown that it sort of enhanced rhinovirus a little bit. The other viruses are actually much harder, and I don't know data that teases out a specific amplifying link. I think with RSV, what's complicated is epidemiologically, we're better at finding it. So we now have better molecular tests. Those molecular tests are run much more commonly. Since the pandemic, we all have little PCR multiplexes that we run in our urgent cares or our emergency rooms. So we find RSV far more readily than when we ever used to hunt for it on antibody swabs. And so I think part of it is an identification issue. We just see it more because we look for it better. I think also there's more chatter about it because we finally have an intervention. There's not a lot of point in having a great test for a virus you can do nothing about. Whereas actually now, if we've got a meaningfully protective vaccine, then I think it's good that we're in fact finding more cases because it highlights actually that there's plenty of stuff floating around that we can protect our patients from.
Perfect. Thank you.
Other questions?
I have one more question, but I'll wait for a non-viral question.
That's okay. Go ahead, Dr.
Can you comment on the screwworm happening happening mainly in Texas, but there is pretty widespread spread on that area. It's increasing. So infrastructure and lack of the vet and making it harder.
Yeah, I had a little section of this talk for other things that are bubbling that I don't have enough time to discuss. And so I actually had a slide on screwworm and I took it out for time's sake. So for those of you that don't know, screwworm is fundamentally a veterinary issue. It's essentially a little vector transmitted parasite that gets into our herds of animals and does really, as the name suggests, sort of burrow its way through tissue. It had been largely or completely, in fact, eradicated from the United States up until the last 12 months. And unfortunately, we've now had spillover cases from northward movement of screwworm through Mexico in particular that have left a number of areas in southern Texas affected. It's mainly still an issue for cattle population, although it can cause human disease. And I think it was last year that we actually had a death due to screwworm in an individual who, actually got burrowing organisms coming through him. It was quite a horrific sounding condition. So I think at the moment it is still rare. I don't know of any other human transmission events that have taken place. It is certainly occurring more frequently in our cattle population in southern Texas, and I think if you are, in the agricultural industry down there, your alarm bells are ringing that this will become more common, and of course it affects then our export markets for our beef and all sorts of other things. What to do about it is tricky because it's not something that is easily eradicated and treated. In fact, my understanding is took like many decades of original eradication. So we're sort of, its emergence is a real threat.
Perfect. Thank you. Well, I'll ask one more question and I'll stop.
Okay.
Bird flu we reported in a year and a half ago in the United States, and there was big, now it's happening in Asia, in more like South Asia, it's happening it. Do you think it's going to come back to the States, or because our investment in bird flu vaccination is very, very poor in the United States? We're not doing the things we should be doing.
I agree.
Any comment on that?
Yeah, I mean, bird flu is another thing, sadly, that's off the front page of the news, but it hasn't gone away. So I think it was just today I saw another cluster occurring in chicken farms in Utah that have been suddenly having to go and cull. So it is absolutely transmitting. So when we talk about bird flu, avian flu, H5 is really what we're talking about, H5N1. It is an influenza that continues to transmit. So we've seen migratory birds finally hit Australia. So it was big news for me when I was, last back in the country a couple of weeks ago that we finally, it's now arrived in some of our native bird populations that otherwise had been isolated. It is on every continent. So we've seen substantial wipeout events in many of the Antarctic islands, up and down the coast of South America. It has hit local seal populations. It affects domestic and wild feline populations. And so, it may be off our radar in terms of human cases, but it is absolutely causing major extinction-threatening events in animal populations. And so, we do still see spillovers. So it was just this week that there were additional H5N1 human cases through Cambodia and Vietnam. And, you think of those countries and they're very, they have often close contact with bird populations. So what we haven't seen yet is we have not seen evolution to acquire the mechanics and acquire the virulence factors within H5 that will allow human-to-human transmission. It's actually genetically a little bit more complicated for H5 to do that, thankfully. And so I don't think we're at imminent risk for that. Probably when we look at countries where there's been substantial H5 human cases, so Egypt has had a very large number of cases. When they actually do serologic surveys of Egyptian populations, they see a lot of antibodies against H5. So it's probably actually been transmitting at pace in ways in humans that we don't fully understand, but makes me a bit reassured that the mortality is not quite as high as we thought it would be. Your ultimate question was, are we doing the right thing in terms of vaccines? And I think, unfortunately, this has been interestingly pushed out of HHS's domain and pushed into both FDA and Department of Ag, because it affected cow populations, because it affects chickens, because it affects poultry. There's reasons to want to do that, but I think it has completely turned the vision away from human prevention. And in fact, many of the trial work, including some at our vaccine institute here at Duke, that were looking at H5 vaccines have been mothballed. So, you talk about sticking our head in the sand. We have buried our head in the sand on H5. And so far, it has not bitten us. But it continues to circulate, and we would expect to see intermittent breakout cases in people who may have had more sick bird or sick animal contact. Thankfully, no evolutionary change that makes it human to human capable.
Thank you very
Other
much.
questions? Other
Appreciate
questions for Dr. Wolf? Dr. Wolf, let me ask you a question. This may be a dumb question, and maybe I wasn't listening, but just to reiterate, for my own benefit, if you have a over 70-year-old elderly patient who's otherwise, he's not a transplant or on dialysis or anything, and he has received last year RSV immunization, he had all the recommended previous COVID shots, he does not need another booster of either of those this year, correct? He would get the flu shot, but he's got what he's got for RSV and for COVID. Is that correct?
Yeah, certainly for RSV, Mike, that's true. We think it lasts well enough that you don't need a second dose yet.
Yeah.
If they're 70, I would err them towards getting both a flu and a COVID. I think there's
another COVID.
Yeah.
Same one they got last year, the same COVID they got last year.
Same one's fine. There's really no meaningful efficacy difference between Pfizer, Moderna, and Novavax.
Yeah.
Am I more concerned for flu in that person? Yes. I think the morbidity of COVID has really dropped away, thankfully.
Thank you. That's great. Yeah, just to make the point. Any other questions, Renee? Is there anything else in the chat?
There is one extra interesting question actually from David Reed, who
I
says
thought something popped up. Yeah, go right ahead.
Are there data on how many infectious individual particles, I guess, are necessary to develop any of these diseases? That is a great question, and so there is some. Norovirus is the top of the list. A minute amount of norovirus, unfortunately, will land you sick, which is why we see such gargantuan outbreaks in nursing homes, in hospitals, in cruise ships. It's felt that hantavirus is actually pretty difficult to transmit, and that can even be with close contact. So my suspicion there, and I don't know that I've seen data on actual particle count, is that actually requires a slightly higher or more protracted exposure, and therefore probably more particles. Whether that's that I'm not secreting more particles or exhaling them, or you need a certain number to inhale, I don't know, but it's certainly much more difficult to acquire. Cyclospora, we think that the amount you need is actually relatively small. But again, it takes a while to develop, and so lots of that is internal replication as it divides in your intestine. I guess the other conditions that we talked about were Ebola. In theory, Ebola needs an absolutely minute amount of transmission of viral particles to make you sick, which is why we go into such laborious effort to try and really keep ourselves viral particle free when we're dressing up to go and see a patient. But again, those particles thankfully are not inhalational, so it's a fluid body transmission, so you can't actually, even though it's a tiny number of particles that you need, you got to have a break in your skin or some way, or a needle stick or some other injury, mucosal splash or something for it to get in. So that's much more difficult in actual fact. I hope that sort of gets to that question.
Perez, is that what you wanted to hear? Any other final questions? This has been really a great session. Okay, well, Dr. Wolf, we won't keep you up any later. We thank you so much for doing this. You were spot on with the whole program. Thank you so much for doing this. For everyone else, we hope you'll join us again next week when Dr. Wong we'll be talking about inflammatory bowel disease. Renee just put into the chat the links or the QR code for the eval forms. Please take a few minutes tonight or tomorrow, whenever you have time, to fill it out and send it back. We hope to see you on a future program. All that being said, as I usually tell the residents, please be careful out there, and we're delighted to have you this evening. Have a great evening. Good night. Bye-bye.
Thanks, Mike. Thanks,
Thanks.
everyone.
Thanks again.